Swayam Prabha. Digital India. Educated India.
Hello and welcome to this session on viral upper respiratory tract infections. Now, the acute respiratory tract infections are responsible for most of the infections experienced by otherwise healthy adults and children. They are responsible for more than 50% of the acute infections, and viruses are responsible for more than 75% of these infections. At the end of this session, you will be able to enumerate the causes of viral respiratory tract infection, and you will be able to describe the etiology, pathogenesis and laboratory diagnosis of viruses causing these infections. Now, as we understand, the respiratory tract is the most frequent portal of entry for infectious agents. Many infectious agents remain localized in the respiratory tract and cause infections, but some of the agents they have to disseminate to produce their characteristic symptoms. Now, the upper respiratory tract infections are the infections which involve the upper part of the respiratory tract, that is nasal cavity, pharynx and larynx. Sometimes these infections they spread to the adjacent areas and cause complication. For example, they may spread to the middle ear and cause otitis media, or they may involve sinuses to cause sinusitis. Sometimes they invade the lower part of the respiratory tract and cause lower respiratory tract infections. Now, both DNA and RNA viruses they are involved in causation of upper respiratory tract infections or URTI, but RNA viruses they are more commonly involved, and the viruses causing URTI are rhinoviruses, human coronaviruses, human parainfluenza viruses, influenza viruses, respiratory syncytial virus, adenoviruses and enteroviruses. Now, many of these viruses they cause more than one type of respiratory illness, and hence etiological diagnosis is not possible just on the basis of the clinical presentation of these infections. Now, traditionally the upper respiratory tract infections they are divided into different syndromes like common cold, pharyngitis, croup or laryngotracheobronchitis and influenza. The most frequent causes of common cold are rhinoviruses and coronaviruses, but they are also caused by other viruses like parainfluenza viruses and influenza virus C. The most common causes of pharyngitis are adenoviruses and herpes viruses, but they are also caused by parainfluenza viruses and Coxsackie viruses. Laryngotracheobronchitis or COOP is most frequently caused by parainfluenza viruses, but uncommonly or rarely it can also be caused by influenza virus C, and influenza is caused by influenza virus A and B. Now, coming to the prevalence of viruses in causation of URTI. Actually, bacteria are responsible for only for 5% of the upper respiratory tract infection. All the remaining infections they are caused by viruses. The most important viruses causing URTI are rhinoviruses and parainfluenza viruses. Influenza is responsible for only 10% of the infection, and the other viruses they include viruses like coronaviruses, adenoviruses and herpes viruses. One should also remember that certain infections like measles, rubella, chickenpox etc., they also start as upper respiratory tract infections. The clinical manifestations of URTI they are usually mild and consist of rhinorrhea, sneezing, nasal congestion, nasal obstruction, postnasal drip and cough. Sometimes they are also associated with low grade fever, sore throat and general malaise. But these clinical features they are not specific for any particular virus. Now, as we have seen that influenza virus does not top the list of viruses causing URTI, but the infection caused by influenza virus, it can be very severe and it can last longer, and it can be associated with life threatening complications in high risk population. Hence, we are going to start our discussion with influenza virus and we will be doing it with an example of a clinical case. Now, the history in this clinical case was like this. A 25-year-old pregnant woman was presented because of high grade fever, chills, severe fatigue and malaise which had started 2 days back. At the time of admission, she complained of generalized myalgia, nausea, mild sore throat and burning of eyes. On examination, it was found that she was a well nourished woman, slightly uncomfortable. She had tachycardia and her respiratory rate was 15 per minute. Her blood pressure was normal. On oral examination, she had pharyngeal erythema without any exudation. Her RS and CVS systems, they were found to be normal. So, on the basis of clinical findings, a case of influenza was suspected and the specimens were sent for laboratory investigations. So, nasopharyngeal swabs were collected and they were sent for antigen detection by direct immunofluorescence. They were also sent for virus isolation and reverse transcriptase PCR polymerase chain reaction for pandemic influenza virus A H1N1. The results were like this. The direct immunofluorescence test and RT-PCR, they were positive for influenza H1N1 and these results were substantiated by positive virus culture. And hence, the patient, she was started with oseltamivir 75 milligram BD for 5 days along with the supportive treatment. She felt better and she was discharged after 5 days of admission and she resumed to her normal health within 2 weeks. So, this is a typical case of uncomplicated influenza which is seen in the clinical practice. So, what is influenza? Influenza, it is a constellation of symptoms like fever, cough, sore throat, rhinorrhea along with myalgia, malaise, headache and nasal congestion, and it is caused by influenza virus A or influenza virus B. So, coming to description of influenza virus, the influenza virus, it belongs to Orthomyxoviridae family. It is a single stranded RNA virus. It is a negative sense RNA virus and the virion has multiple segments. In influenza A virus, 8 segments are present and in influenza C virus, 7 segments of RNA are present. The virus has helical symmetry. It is 80 to 120 nanometer in size. It is an enveloped virus. The virus has 8 structural proteins and 2 non-structural proteins. The envelope of virus, it is lipid bilayer and its envelope is studded with glycoproteins which are known as peplomers. There are 2 types of peplomers present in influenza virus, hemagglutinin which is triangular shaped peplomers which are present on the surface and they attach to the sialic acid receptors which are present on the epithelial cells of the respiratory tract. So, these peplomers, they help in the attachment of the virus particle to the respiratory epithelial cells. There are another types of peplomers present on the surface which are mushroom shaped and they are known as neuraminidase. The neuraminidase, they are in fact sialidase enzyme and they help in the release of virus after replication from the infected cell. They also help to pass through the mucus which is present on the mucosa of the respiratory tract. Coming to the classification and nomenclature of influenza virus. Now, the influenza virus, it is classified on the basis of the nucleoprotein antigen and M proteins present in the virus into 3 genera, influenza virus A, B and C. The influenza A virus is further classified on the basis of hemagglutinin and neuraminidase antigens. There are 18 hemagglutinin or H antigens identified so far and 11 N antigens have been identified. All these antigens, they are present in the avian strains of influenza virus. However, in human strains of influenza virus, only H1, H2, H3, H5 and N1 and N2 antigens have been identified. For nomenclature of an individual strain of influenza virus, the following information has to be used. What is the type of the virus, whether it is type A or B, the host from which the virus has been isolated. The host is mentioned only if the strain is isolated from non-human host, the geographic origin of the isolation, the strain number and the type of H and N antigens, that is subtype H1 and N1 subtype. So, in this particular example, the influenza A, the virus isolated was influenza A virus, it was isolated from Texas. Since the strain was isolated from a human source, the host has not been mentioned. The strain number given was 50. It was isolated in the year 2012 and the H and N subtype was H3N2. The second example is, again it is influenza A virus which was isolated from pig. So, host mentioned is swine. It was isolated in Iowa. The strain number was 15 and H and N subtype was H1N1. So, this is how the nomenclature of individual strain of influenza virus is done. Now, the H and N antigens of influenza virus, they undergo independent antigenic variation. Two types of antigenic variations have been described in H and N antigen. The one type of antigenic variation seen is known as antigenic drift. The antigenic drift is because of the minor antigenic changes in the H or N antigen because of the accumulation of point mutation. The second type of antigenic variation that is observed in influenza virus is known as antigenic shift. Now, this antigenic shift is because of the reassortment of the different strains. So, this is usually seen when a cell, single cell is infected by two strains, two or more different strains of originating from different species. For example, when a single cell is infected with one strain of avian influenza virus and one of human influenza virus, then during replication there can be exchange of the RNA segment, and because of that antigenic change occurs, and this type of antigenic variation is known as antigenic shift. So, antigenic drift, it is a gradual antigenic change in the influenza virus, whereas antigenic shift is a drastic change in the antigenic nature of the influenza virus. So, antigenic drift is usually responsible for the small epidemics or outbreaks, whereas antigenic shift is responsible for the pandemics of influenza virus. So, the pandemic strains, they are usually originated because of the reassortment. Reassortment usually occurs in pig, which acts also as a mixing vesicle. So, when the cells of the pig which are susceptible to infection by both avian strains as well as human strains, during replication the exchange of RNA segment occurs and reassortant strains, they originate. Usually they are responsible for the pandemics. So, if you see the history of influenza pandemics, the most recent H1N1 2009 strain was originated in California, USA, and it has been responsible for the most recent pandemics of influenza. In last 2 centuries, there had been many pandemics of influenza due to different strains. The most severe pandemic was experienced in 1918-1919, that is known as Spanish flu. One more pandemic was seen in 1957-58 and the latest pandemic has been seen in 2009. In between also there were some pandemics which were not so severe as compared to the earlier 2 pandemics. In between the pandemics, the influenza virus undergoes antigenic drifts and small outbreaks are experienced. Now, coming to the pathogenesis of influenza virus. The transmission of influenza is usually an airborne transmission, but fomites also play some role in transmission of the infection. The sialic acid receptors present on the epithelial cells, the virus gets attached to these receptors and enter the epithelial cell of respiratory tract. Local multiplication of the virus occurs and it is spread to the adjacent cell. And finally, there is local damage to the mucosa and there is desquamation of mucosa of respiratory tract. Coming to the clinical manifestations, as we have seen in the clinical case that the manifestations in uncomplicated influenza are headache, fever with chills, myalgia, malaise, sore throat, rhinorrhea and nasal congestion. But sometimes there can be life threatening complications also, and these may be the primary viral pneumonia, there can be secondary bacterial pneumonia, there can be mixed type of pneumonia, primary viral as well as bacterial pneumonia, there can be sometimes exacerbation of chronic pulmonary conditions, and there can be complication like Reyes syndrome if patient is given salicylate for the management. Then coming to avian influenza in humans. Now, avian influenza in humans, it is transmitted when person comes in contact with infected poultry. Now, the most common strain which has caused many outbreaks in humans is H5N1 strain. These strains, they are not transmitted from human to human. So, human to human transmission is not recorded. The strains are highly virulent and there can be complications like pneumonia and multisystem involvement can also occur. The other avian strains which have been reported are H7N7, H9N2 and H7N9 strains. Now, coming to laboratory diagnosis of influenza virus infection. Now, the specimen collected are nasopharyngeal washings, nasopharyngeal swabs and throat swabs. If the swabs are collected, then they have to be transported in a viral transport medium, and during transport cold chain has to be maintained to prevent the inactivation of the virus. The various methodologies used for diagnosis are isolation and identification of virus in embryonated egg or cell culture, direct detection of antigen by direct fluorescent antibody technique, various molecular tests can be used and there can be demonstration of specific antibody in the serum. For isolation of influenza virus, embryonated egg of 10 to 11 day age can be used. The specimens are inoculated in amniotic and allantoic cavity. The eggs are incubated at 33 to 34 degrees centigrade for 3 to 4 days and the fluid harvested from the amniotic cavity and allantoic cavity are tested for presence of hemagglutinin. The allantoic cavity inoculation is especially used for production of influenza vaccine or when large amount of yield is required for the laboratory testing. The influenza virus can be isolated in cell culture. The various cell lines used for isolation are primary monkey kidney cells, Vero cells, human diploid lung fibroblast and Medin Derby canine kidney cells. The growth in the cell culture is identified by cytopathic effect or by hemadsorption test. For identification of subtypes of influenza virus, hemagglutination inhibition test or direct immunofluorescence can be done. In this slide, you can see the cytopathic effect, that is morphological effects produced on the MDCK cell line after growth of influenza virus. On the left hand side, you can see uninoculated MDCK cell line and you can see cytopathic effects after inoculation in the inoculated cell line. You can see that the cells have been enlarged, there are gaps in the cell that can be seen and the cell line has been or monolayer has been detached from the surface. Hemagglutination is used for screening of virus growth either in amniotic and allantoic fluid or in tissue culture fluid. For identification of subtypes, hemagglutination inhibition test is done. The molecular tests used for diagnosis of influenza virus are RT-PCR and real-time RT-PCR. In RT-PCR test, the RNA of influenza virus is first reverse transcripted into a complementary DNA and it is amplified using polymerase chain reaction. In real-time RT-PCR, the quantitation of influenza virus is done. This test can be used for detection of virus in the clinical sample and can also be used for detection of virus in the culture. These tests, because they are simple, specific and rapid, they are rapidly replacing the conventional tests used for diagnosis of influenza virus. Serologic tests like detection of antibody can also be used for diagnosis of influenza virus. The various tests that can be used are complement fixation test, heme agglutination inhibition test, neutralization test and enzyme linked immunosorbent assay. For demonstration of antibody, 2 serum samples, that is paired sera, one collected during the acute phase and the second collected during the convalescent phase are to be tested. But antibody detection tests, they are not routinely carried out for diagnosis of influenza. For management of influenza virus infection, antiviral drugs are available in the form of neuraminidase inhibitors like oseltamivir and zanamivir. There are also drugs available which are M protein inhibitors like amantadine and rimantadine. One should keep in mind that during management of influenza infection, salicylates should never be used in children less than 18 years of age. For prophylaxis of influenza, vaccine is available. The vaccine composition needs to be changed each year. Usually, the vaccine contains 1 or 2 strains of influenza type A strains and a strain of influenza B virus. For preparation of vaccine, the virus is grown in the allantoic cavity and it is inhibited with either formalin or beta propiolactone, and the dose is adjusted as hemagglutinin content of 15 microgram per dose. The vaccine is introduced intramuscularly or subcutaneously as a single dose every year in high risk population. Now, coming to parainfluenza virus. Now, parainfluenza viruses are again very important cause of upper respiratory tract infection in all ages, but they cause very severe infections in children and in infants. Human parainfluenza viruses, they belong to Paramyxoviridae family. They are negative sense RNA viruses and the size is about 150 to 200 nanometer. They are enveloped viruses and the envelope has presence of 2 proteins. One is fusion protein, that is F protein, and another glycoprotein present is HN glycoprotein. The fusion protein is responsible for the fusion of the virus particle with the cell membrane. So, it enhances the or it facilitates the entry of the virus. HN glycoprotein is responsible for the attachment of the virus to the respiratory epithelial cells. The paramyxoviruses, they are classified into 4 different types, 1, 2, 3, 4. 4 is further classified as A and B. The infection is transmitted by large droplets or person to person contact. The incubation period is about 3 to 6 days. Now, parainfluenza viruses, they cause 3 types of illnesses in human beings. One type of infection is acute febrile illness, which is characterized by presence of coryza, sore throat, hoarseness, cough and fever. It is caused by types 1, 2 and 3. The second type of illness caused by parainfluenza viruses is COOP or laryngotracheobronchitis, a very serious condition seen in small children. It is characterized by presence of persistent fever, worsening coryza, barking cough and inspiratory stridor. It is caused most of the times by type 1 and sometimes by type 2 of parainfluenza virus strains. The third type of illness caused by parainfluenza viruses is lower respiratory tract infection, which is usually caused by type 3. For laboratory diagnosis of parainfluenza virus infection, the specimen collected are nasopharyngeal swabs, nasal aspirates and throat swabs. The most commonly used tests are demonstration of antigen by direct fluorescent antibody test or by indirect fluorescent antibody test using monoclonal antibodies. The virus can be cultured using cell culture. Primary monkey kidney cells are used and this virus does not produce cytopathic effect. So, growth of virus is detected either by heme adsorption or direct fluorescent antibody test or indirect fluorescent antibody test using monoclonal antibodies. Serological test can also be used using heme agglutination inhibition, complement fixation or enzyme linked immunosorbent assays. Coming to the next virus belonging to Paramyxoviridae family, that is respiratory syncytial virus. Now, this virus, though it causes upper respiratory tract infection, it is the most important cause of lower respiratory tract infection in children. It causes fusion of the cells and formation of multinucleated syncytium in cell culture, and hence it is known as respiratory syncytial virus. It is a paramyxovirus, so it has negative sense single stranded RNA. The envelope has 3 types of glycoproteins, F fusion proteins, G glycosylated proteins or SH proteins. Coming to the clinical manifestations of RSV, the infection is transmitted by droplet infection or direct contact. It causes mild upper respiratory tract infection in the form of cough, low grade fever and rhinorrhea. The most important disease caused by RSV is lower respiratory tract infection in the form of bronchiolitis, tracheobronchitis and pneumonia. For laboratory diagnosis of RSV infection, nasopharyngeal swabs, bronchoalveolar lavage and bronchial washings are collected. The antigen detection can be done by direct fluorescent antibody, indirect fluorescent antibody test, enzyme linked immunoassays and chromatographic immunoassays are also available for demonstration of antigen in RSV infection. The virus can be cultured in HeLa or Hep2 cells. The identification is done by syncytium formation and also by negative heme adsorption test. For rapid cultivation of virus, shell viral culture can be used. Human metapneumovirus is again a paramyxovirus which is almost similar in pathogenicity to respiratory syncytial virus. It causes mild upper respiratory tract infection and also lower respiratory tract infections. Then coming to another group of viruses, that is human coronaviruses, which are the most important causes of common cold. It is widespread in distribution and besides upper respiratory tract infection, it also causes diarrhea. The human coronavirus, it is a single stranded positive sense RNA virus. It is an envelope virus and the envelope of virus, it is studded with club shaped peplomers. These peplomers gives the virus an appearance of solar corona and that is why it is known as coronavirus. The most important pathogenicity of coronavirus is common cold. The 2 types of strains are found in coronavirus. The common cold strains, important strains are 229E and OC43. The other important strains of human coronavirus are SARS coronavirus strain. SARS is severe acute respiratory syndrome coronavirus and the second is Middle East respiratory syndrome, that is MERS coronavirus. The infection caused by these 2 coronaviruses, they are extremely serious and multisystem disorders. The SARS or severe acute respiratory syndrome, it is a multisystem disorder and the virus can be found besides respiratory tract, it is also found in blood, urine and stool. It causes desquamation of the pneumocytes, formation of hyaline membrane and interstitial infiltrates of the mononuclear cell. The clinical manifestations are fever, myalgia, malaise and non-productive cough. Most importantly, it causes adult acute respiratory distress syndrome. So, there can be multi-organ dysfunction and a very high mortality has been reported. For laboratory diagnosis of coronaviruses, for common cold coronaviruses, the laboratory diagnosis is not required, but for SARS and MERS coronaviruses, the laboratory diagnosis can be done by reverse transcriptase PCR using respiratory samples or plasma, urine and stool samples. Antigen detection can also be done using ELISA using monoclonal antibodies. Coronaviruses, they are difficult to cultivate in vitro, but SARS coronavirus can be easily cultivated in vivo E6 cell line. Antibody detection can be done using ELISA tests. Coming to the rhinoviruses, again very important group of viruses causing common cold. It is worldwide in distribution, and most of the infections caused by rhinoviruses, they resolve without any complications. The rhinoviruses, they belong to Picornaviridae family, hence they are single stranded positive sense RNA viruses about 50 to 30 nanometer size. They are non-enveloped viruses. They grow preferentially at 33 to 34 degrees centigrade, and more than 102 serotypes of these rhinoviruses have been identified. They are transmitted by direct contact or droplet infections. The incubation period is very short, that is 1 to 3 days. The infection rate of rhinovirus infection is very high in children, and because most of the infections resolve without any complication, the laboratory diagnosis usually is not required or not attempted. There are other picornaviruses like enteroviruses. They are also involved in causation of common cold. The enteric cytopathogenic human orphan viruses, commonly known as ecoviruses, many serotypes of ecoviruses are also involved in causation of common cold. Coxsackie viruses type A and B, they also cause common cold, and Coxsackie A virus, it can cause vesicular pharyngitis. The last group of viruses causing upper respiratory tract infections are human adenoviruses. Now, human adenoviruses, they infect and replicate in the epithelial cells of respiratory tract, GI tract, conjunctiva and urinary bladder. They are also common cause of gastroenteritis besides upper respiratory tract infections. The adenoviruses, they are double stranded DNA viruses which have icosahedral symmetry. The shape of the virus is very typical. It is from the apices of the icosahedron, the protein fibers come out and they give an appearance of space vehicle to these viruses. 51 serotypes of adenoviruses have been identified. However, 1 to 7 serotypes are responsible for most of the infections. The upper respiratory tract infections are caused by serotypes 1, 2, 3 and 5. Serotypes 3, 7 and 21, they are involved in causation of pneumonia. Acute respiratory attacks in military recruits are caused by usually serotypes 4 and 7, and serotypes 3 and 7, they caused pharyngoconjunctival fever. For laboratory diagnosis of adenoviruses, the specimen collected are throat swab or conjunctival swabs. The antigen detection can be done by direct fluorescent antibody test. The virus can be cultured in laboratory using HeLa and Hep2 cells, and the identification can be done by cytopathic effects. The cytopathic effects are very typical. There is rounding and grape-like clustering of the cells, and the strains can also be identified using polymerase chain reaction. Antibody detection can also be done using neutralization, complement fixation and ELISA tests. So, this was about the viruses causing upper respiratory tract infections. So, at the end we can summarize that viruses are the predominant cause of acute respiratory infections. Rhinoviruses and coronaviruses are the commonest causes of common cold. Human parainfluenza viruses, they cause severe respiratory tract infections in children and in infants, and influenza virus infection can be associated with complication in high risk population. Thank you.